The future of healthcare will be shaped through data and technology. In a world that's brimming with digital advancements, the healthcare sector is facing a tricky paradox. The potential of analytics and interoperability is huge, but the journey ahead is challenging. In this episode on the podcast, we feature a live stream conversation that I had with Andrew Aho from Intersystems and Robbi Karp, the CEO of Fluffy Spider Technologies and a board member for HL7 Australia. We had a conversation as a live virtual event recently and had hundreds of attendees across LinkedIn and YouTube help shape the discussion in real time. If you're keen to check out these live recordings in the future, make sure you're subscribed and following us on LinkedIn and YouTube and our other social medias so you don't miss the next one. In this episode, you'll hear me speak with Andrew and Robbi as we unpack the findings of the latest State of Analytics and Interoperability study from Intersystems and navigate through the complexities of data-driven healthcare transformation. And in this episode, we talk about why some healthcare leaders still hesitate to fully trust their data. How can the industry bridge the gap between clinical needs and administrative efficiencies? And is the dream of seamless data integration in healthcare a distant reality, or are we on the cusp of a breakthrough? Collaboration starts with a conversation, Team HealthTech. Let's make it up.
Welcome to Talking HealthTech, featuring content and community about technology and healthcare. We acknowledge the traditional owners of lands these conversations were recorded and pay respect to elders past and present.
So we're here live, going live across LinkedIn and YouTube here on Talking HealthTech. My name is Peter Birch. Looking here, I can see some people are already arriving, and make sure you leave a question and a comment in the chat so that we know that you're here. Whatever platform you're on, we can see those comments coming up as we go through this conversation today, because we've got a panel with us, and a small panel, a panelette, is that the term? I'm not sure if that's a correct term, but of people that I'll get to introduce yourselves first. We've got Robbi from Fluffy Spider Technology and Andrew from Intersystems. Thanks for joining, gents.
Pleasure to be here.
Excellent.
Thank you.
And so for those that don't know you, firstly, I might get you, Andrew, to introduce yourself. Tell us who you are and what you do.
Sure. Thanks. Very good to be here. So Andrew Aho. I'm the Regional Director for Data Platforms at Intersystems. I've been around AI, data analytics for probably a few too many years that I prefer to let on, but certainly love this area of technology, and real pleasure to be here on your show today. Thanks.
Excellent. Thank you. And Robbi?
So I'm Robbi Karp, CEO of Fluffy Spider Technologies. We specialise in interoperability solutions. We're Intersystems partners. I'm also on the board of directors to HL7 Australia, as well as some other Australian startups and medtech companies.
Excellent. Thank you. And look, we can see those comments coming through on the chat here as well. G'day, Michelle, joining on LinkedIn. If you're on YouTube, and I believe it's also going out on Facebook as well. So really pushing the boundaries of a live conversation here with people in person. And it's great too to be able to do it because we've got here the State of Analytics and Interoperability study. This is the second one, I believe, that Intersystems have done, titled Healthcare Organizations Data Journey, the Way Forward. And Andrew, I might get you firstly to set the scene a little bit more about this particular study and the survey and the results that have come out. Like, what are we looking at here?
Yeah, sure. So it's the second year, as you said. The year before last, we were having a look at our customers routinely ask us about how to get more out of their data for various purposes, analytics being one of them. And whilst we helped with that, we were trying to help provide some context as to what healthcare executives are seeing and finding, and what the challenges might be as to, how do you actually get more out of your information. So we partnered up with a research partner, Ecosystem, and they conducted this research. The first year was last year, and then the second round has been this year. So it covers 240 odd people who've now responded. Healthcare executives. It is predominantly hospital focused, but there is a good mix of different settings there. So I think the majority is public hospitals, but there's a good number of private. And they also talk to the regional as well as the metro centres as well.
Particularly in Australia?
Australia and New Zealand.
Australia and New Zealand, yes, that's right. Yeah. Amazing. So, look, I came to understand what some of these insights are. And I remember we've spoken about, this study, the research that was done last year as well, this being the second one. And one thing that did, pique my interest first, and it's kind of come through here too, is around this point of trust that healthcare leaders have in data. And looking here at some of the outcomes, a lot of around half of healthcare leaders surveyed don't fully trust their data, but only 35% of organizations have a holistic data strategy to address this. Like, this disconnect between, why organizations don't trust data, trust the data that they've got, and the investment that's needed into the infrastructure. Walk me through some of the thinking on what might be happening there.
Yeah, sure. Well, look, trusts and data quality obviously go hand in hand. And it's interesting because the last few days I've been at a conference all about AI in healthcare. And so the conversation there is very much, because, AI is in nearly every conversation at the moment. How do we have safe, secure, private use of AI, and what are the governance implications, ethics, explainability, and all the other parts that go into having some kind of AI that you can trust. And to me, you can have all of that in the world, but if you haven't got high quality data that's trusted, the models are only going to give you so much in return. So obviously this is a key issue, and as you mentioned, the research does highlight that only a proportion, 35%, have a holistic data strategy. And so in that holistic data strategy, those organizations are thinking about those things: governance, data literacy. How do we get people to understand, utilize the data more, which leads to higher quality data and higher quality understanding, which does lead in turn to trust of the data. We have found that in the other organizations that don't have this holistic data strategy, a lot of them are thinking about a single repository. That's their data strategy. Let's get the information into just one place. Or how do we increase the availability of data so it's more real time? So I think the idea is to try and move towards this more of a holistic strategy where we think about data in every part of our business, and how does that actually help us to grow and to change and to improve clinical care and outcomes. You also mentioned about the disconnect. So that was another key finding in the research, which is whilst these healthcare executives really do want to see more of their investments directed towards clinical outcomes, patient outcomes, patient experience, and probably third on the list is then cost optimization. Where the money actually ends up is in complying with government mandates.
Yeah, right.
Right, and so that's one of the main reasons why these investments aren't leading to that higher quality data and more cohesive strategies. But I think as we go through other parts of the survey, there are other reasons behind this as well.
Yeah, that's interesting. And there's all those important things like the government mandates, or what the ticket to play type stuff. You've got to get out of the gate and meet those minimum requirements. But if they're not, there's all these extra opportunities too. And I think in the clinical setting, you've got both, as you mentioned too, and I can see some of it here, improved patient outcomes as one, and the clinical objectives that exist there, identify risks and reduce errors, and improve patient outcomes. But also from an administrative side, there's a lot of the costs involved within the healthcare system. And I'd imagine that there's some priorities there around, from the administrative perspective, of reducing those costs and optimizing processes. Sometimes these two things can be, in competition with each other, or quite different kind of priorities. How do you find, that in looking through some of these responses and reflecting on that, how those two kind of competing demands might work with each other?
Yeah, look, I think there's a lot to be said on that particular topic. There has been and will continue to be friction around, should we spend the investment towards the best patient outcomes? And I can understand the clinician point of view that is unequivocal. Obviously, if we could improve patient outcomes, it's something we can do. But I think there's an argument to be made, and I think we're seeing kind of a virtuous cycle where if you can justify the improvement or the reduction in costs also with clinical benefits, then that can help release future funding for more clinical improvements, right? So I think the two worlds can live together. In fact, I was talking with a CMO recently who shared with me that fiscal leadership is now becoming as important to the CMO and CMIO role as clinical leadership. So I think this is changing, and we are seeing we have a partner here in Australia called Mirus. They are helping us to bring employment and staffing costs to theatre planning, and that really does help give organisations a view not only kind of how they're allocating resources, but what the impact of those costs will be. Now, it can be framed in the light of helping to reduce clinician burnout because you're looking at things like overtime and reducing that. So it does have some clinical outcomes, but I think mixing these two worlds in a clever way is going to be more of what we'll see in the future.
Yeah. I guess building on that too.
If I could just interject.
Yeah.
The thing we're seeing, so I think that's correct, but sometimes it's really difficult to really measure what the benefits are financially. So I was talking to an IT director for a brand new hospital last week, and it's a day surgery place. It's nobody's sleeping there, but they're actually going to be implementing paper-based systems for everything besides their PAS, okay, and the actual machinery, because for them they can't see the benefits, the long-term benefit of implementing anything besides that. It's expensive, so they really need to be able to see what those costs are, how the overall cost is going to be brought down. So I think what you're saying is correct. So we need to see how it all sort of bundles together, in the future.
Absolutely. It is interesting that paper is very much part of the data strategy, but interesting to hear that it's part of people's moving forward strategy.
This is a Greenfields. Right? Yeah. Did I mention this is a Greenfields hospital? So they have the opportunity to start from scratch.
Well, that's interesting in itself, isn't it? I think about the, building on that around the business case, Robbi, of implementing key elements of this holistic data strategy with interoperability and these pathways forward. Even in these examples of greenfield sites, the opportunity to build something from scratch. You need to be able to demonstrate this business case to make investments into things beyond just bits of paper to meet the minimum requirements. Talk me through that.
Well, I think what's really important to note, and it should be obvious, but interoperability and the analytics, they're not in any way at odds. They actually work towards the same purpose. You can't do the analytics if you don't have access to the data, which is facilitated by interoperability.
Yes.
So in a couple of examples, there's one company that we're working with that they get real-time analytics. They get real-time messaging from beds, admissions, discharges. They use that to, in real time, optimize workflows in the hospital command and control center to, work out where the beds should go and that sort of thing. So there's a case where your messaging is facilitating real-time analytics and optimization. In another case, we working with a company that has developed a healthcare product for consumers, and so it's something that will sit on a person's skin and monitor some signs and put that via their cloud into an EMR. So so the outcome there is by being able to analyze the data, you optimize the outcome for the patient. So I'm using those two examples because in one case we're writing into an EMR, in another, by messaging, interoperability. In another case, we're reading from an EMR. Both of those things need to be done in order to optimize the overall process. I mean, the thing about value-based care is that you can achieve improvements in the patient's overall healthcare by making the measurements, by improving every step of the way. The more you do that, the less a patient is in hospital, you know. And so the whole process is optimized, the costs are reduced. You need to look at it as an overall overarching strategy.
Yeah, it's very, very true. The value-based care, I think, is a key part of this, and there are some countries around the world that are really taking that very seriously now, and I believe we'll see more of that here. And it forces you to look at multiple aspects of how care is measured and what quality and the fiscal side of things are. And look, we've got a few examples which are sort of heading in that direction. But to come back to the justification and the business case for doing these sorts of things, that medical device integration one, Robbi, we've talked about a lot. We do have a project here in New South Wales where they're connecting up medical devices, bedside monitors in the ED, and directing that information through to the EMR. There's a bit of workflow in the middle so that clinicians can approve it. It doesn't necessarily automatically go through, although in some cases it does. But that has been able to be justified on, again, reducing clinician burnout, because what were they doing before? Manually writing down the results and transcribing them, or putting them in.
And there are mistakes in those processes as well, by the way.
Absolutely.
And if you digitize those things, those mistakes go away.
Yeah. So I think there's that can be really powerful even before you start thinking about the AI or the ML implications of what you might do in terms of clinical alerting, deterioration, those types of things, to avoid more patient harm with the data later on.
Yeah, absolutely. I'm going to pause for a second here because despite the fancy cameras and the real-time setting, we are indeed live, and I can see those comments coming through on LinkedIn and YouTube here. Charles summarized it in one sentence there of you can only analyze the data you can access, and that ties in nicely with what we've mentioned before. We're no doubt going to touch on the question that David's already raised of his healthcare interest in adopting generative AI and large language models. That's definitely the talk of the town at the moment. Thank you, Amy, for also putting the link to the report, which you can download, which is available within the links, within the comments here on LinkedIn. Also, when you're listening or watching this episode afterwards too, on the podcast, available in the show notes. Michelle's asked a great question in relation to interoperability, some of the challenges that healthcare systems might have, particularly if they've got some of their own systems versus other ones. But we can dive into that in a second. But I actually so I encourage anyone that's watching live across any of the platforms, put your question in. We can put it up on the screen and discuss it here within the conversation, and get a mention on the podcast recording that comes out later too. So just back to this point that was already kind of touched on, which I guess had the flavour of staffing and people. We were talking about clinical workforce for a second there, and in relation to the burnout point, which is certainly an aspect. But I think about this capability and the need to do some of this analytics that we're talking about, Robbi, where, on one hand, you need the data to be interoperable so you can do the analytics, but you need the people and the workforce and the capability to be able to do that too. And I think somewhere within this report as well, some of the findings are around, that organizations feel that just having the lack of skills was a challenge in adopting some of these this analytics capability, and then either didn't have the skills and or didn't have the budget. So given those are the challenges, like how do healthcare systems realistically address some of these?
So training is the way to address these things. The technologies are new. HL7 Australia, by the boost in the May 23 budget from federal budget funding, is to support the Australian Fire Management Framework, is for the governance of the fire standard in Australia. So through HL7 Australia, in conjunction with the CSIRO, the Australian Digital Health Agency, we're running fire connectathons, and the purpose of the fire connectathons is to get a deeper understanding at the developer level of how to create solutions using fire. In addition to that, we have the Sparked Community program, which is to accelerate the use and national rollout of Australian-specific fire standards. So it's got to be about education, and the thing is that organisations need to support these kinds of programs, and by support I mean they need to make time for the staff to go and train, to go and understand. The technologies are new, and if they don't go and learn the new processes, the new technologies, the new systems, learn what's available, learn how to what's good for their organisation, it's going to be very difficult. So it needs support across the board. So that HL7 Australia is doing one part of it by the Connectathons and the Spark Community program, but it needs more than that. It needs the participation of the industry across the board. It's not just for technical people; it's for everybody.
Yeah, absolutely. And that's so Intersystems is one of the founding members of the Sparked Fire Accelerator, and I think it's really a wonderful thing, and I encourage people to be part of it. As you said, Robbi, it doesn't just have to be specific to industry, but to make this work in Australia and to have truly interoperable healthcare, we need to have this foundation. And it's kind of ambitious as well, because fire is now a standard that's been around. It was created here in Australia by Graham Grieve, for those who don't know, 10 or 11 years ago, I think. And it made its way over to the US predominantly. It's in multiple places around the world, but they had the Argonaut program, which is akin to what we have here for Sparked. And that took several years, I think 5 or 6, maybe even longer. And we're trying to do basically the same thing in the next couple of years. We have an advantage, and a lot of the hard work has been done in other parts of the world, and we're not trying to change everything, but it still is a challenge that requires this community involvement really everywhere.
Yeah, it is important to bring those different stakeholders together and take that kind of maybe a staged approach or a methodical approach to this, because if I think about from the perspective of healthcare leaders, particularly those that were, asked for their feedback in this particular report, that there's people want to see change in their existing data mechanisms, but it's to do standardization and real-time access and improve workflows. It can be overwhelming. It needs something of a strategy behind it. It's not something that you can kind of just do. Like, where do you start with this kind of thinking from a healthcare leader's perspectives in perhaps methodically implementing some of these, Andrew?
Yeah, there's I think where you start, there's going to be contextual. So depending on your organisation, and maybe it's different for a greenfield compared to an established company. But one of the key things here is that it doesn't have to be a complete rip and replace, a migration.
That's the thing.
Absolutely. So I think there are other options, and whilst a full let's just start from scratch and re-platform or whatever it might be can make sense in some contexts. So one great example that we have with Intersystems here is PainCheck. So another one of our partners, they have a really clever app that allows you to take a photo, a short video of somebody and determine, using a scientific rating scale, how much pain they're in. And PainCheck has been very successful in the aged care market, particularly where people might have trouble communicating or are non-verbal. And so this does help in a number of ways, including not over-medicating or under-medicating, and patient experience and quality at kind of end of life and things like that. So, but they are by no means legacy. They are by no means not modern. They have a cloud-based system that's I think they've been around 6 or 7 years. And so when they were thinking about entering the hospital space and having to deal with HL7 and FHIR and other data formats, they came to us and we had a conversation around, well, what if we could help you keep all the great stuff that you've got, but by creating call it an integration hub or a wrapper, so that any EMR out there can have data flowing between your system and theirs, and vice versa. So I think there's also opportunity here to reuse what you've already got without having to throw the baby out with the bathwater.
Yeah, what I wanted to say to this, and I think this probably touches on Michelle's question a bit earlier. Look, some of these are very, very complex, large-scale systems. You're not going to make them all interoperable at once. You know, there's just too much to do. So what you need is a very staged approach to it, a way to migrate. And the first step of that is really cloud enablement, whether that's a public cloud or like inside a private cloud. You know, you need a way to effectively take the existing systems. And I don't mean, you know, you can't just take a system, put it in a VM, chuck it on the cloud, and all of a sudden it's, you know, there it is, it's cloud enabled. That's not the way you do it.
Right.
When I say that, you know, what we do is we cloud enable this system by creating a cloud layer with APIs that effectively give them the opportunity at their own leisure, at their own pace, to migrate to the cloud system by system. But by doing that, now they, you know, all of the other systems can connect to their cloud-based APIs. And it doesn't have to be an all or nothing. They replace, or they don't replace, or they migrate slowly, and it can be manageable, cost-effective, that sort of way.
Yeah, I think one other kind of point around this, we were talking about staffing challenges before, and there is more material in the paper around that. I don't think anyone who's tried to hire staff in the last few years would argue it's been, you know, quite a challenge. For, you know, obviously with COVID and people offshore skills not being able to come in, and then it really is just hard to find people with that mix of clinical and technical, or technical and business. You know, that combination of skills that allow them to be effective in this sort of area, let alone the costs and maybe not having budgets. So I think what you were saying, Robbi, about having education and training, a lot of that has stepped up in this country, but it's still early stages. So one of the things that you can do is at the beginning of this process is just to do an organizational readiness assessment. And I remember a few years ago we were implementing it was an EMR program actually, and the team on the customer side took a pause in the early stages of discovery to say, hey, we actually don't have a good handle on exactly what our challenges are around data and digital literacy. And what they found was some people who weren't even familiar with email, heavily reliant on SMS. So if the next day you're going to turn on a fully electronic system, or 12 months, 18 months, those people are going to be, they're going to need help to get onto that journey. So
just like, you know, as a sort of analogy, I've seen over my career, a company will create a brand new, something really quite generationally transformative product, and it will change the way things work. And they'll put it into an organization, and they'll come back, you know, a month later to see what it is, and it's in the cupboard, turned off, you know, because nobody knows how to use it. It's just different. It doesn't matter how ubiquitous it is. It's got to fit in, and by fitting in, there needs to be the process to train people to use it, to, you know, make it part of the workflow. It's really not useful otherwise. Yeah. So the training is critical.
Yep. You know, and I guess I think you referenced Michelle's point earlier, and I think we've touched on a lot of that already, as, you know, where she's asking if the part of the problem of interoperability is that sites and organizations all kind of have their own systems that don't talk to each other, and you know, often the issue is seen as the cost of buying products. I think that speaks to, and her question is, how do we change that thinking so that organizations understand the value of easy interoperability? I think coming back to that point that you mentioned just then, Robbi, around workflow and what fits in, and the training and enablement there, those are really important. Any other points, points that we wanted to raise on that particular question?
Yeah, I think if it's as much creating the business case or understanding the value for something like fire, obviously there is a cost to interoperability, and particularly there's a cost if everybody's doing different things, right? So from an organizational perspective, whilst fire might be something relatively new and it's an investment that needs to be undertaken, you know, largely there will be amounts of what we do today in terms of interoperability that hopefully can be reduced and minimized, i.e. cost out, by moving to standards like this.
What he said, basically, the standardization, it just comes down to the systems need to be talking the same language. We're not going to get any of the data flowing otherwise. That's what standards-based communication is. And so that, organizations need to see at the end of the day how it'll be a cost optimization, how it will be of value to the patient.
Yeah, absolutely. And coming back to getting started with that, I mean, as I said, the other standards aren't necessarily going away tomorrow. So just because you pick fire doesn't mean that that's going to be the only thing that you'll be able to work with. But we have an example I found out recently of one of the very first HL7, which is the predecessor to fire. One of the very first HL7 interfaces was built on an Intersystems platform here in 1987 or 88, something like that. And it's still running today.
Right.
Yeah, it runs on our latest tech, obviously, but those things can be around for a very, very long time. So being able to choose a vendor that allows you to operate with the old and the new and not have that become your burden, constantly trying to manage these things is important.
I think part of it is, and that's a very good point. Something when some of these older systems were first rolled out, it was a case of we're developing the system. Here's the communication. It's set in stone. It's never going to change. So we'll just do it like this and it's done. And, 10, 20 years later, whatever it is, it's still the same. But we're progressing from that. We want to be able to take advantage quickly of new technologies, new ideas, new ways of doing things, because we're building on top of each other. The communication standard, the fire standard, that's just like the first step. We need to be able to build on that to innovate and innovate more. And so the concept of having it set in stone and now it's never going to change, we're past that, or we should be past that. And that needs to be understood. The value, again, to the patient of being able to really take advantage of new systems, stuff that is in the university today, AI-based systems, all sorts of things, new sorts of sensor devices. These can only be taken advantage of if you can bring them into the workflow. Again, these themes come together all the time. So things like HL7, that's a really good example, that 1987 one, and I can just see that.
Yeah, exactly. Yeah,
Well,
and I think. Sorry, go ahead.
No. I was going to say, probably a good time to reference. I can see here in the comments on LinkedIn, Andrew Aho has mentioned that his experience in collating. We're getting into the weeds here, but we can do that because we've got Robbi here to help us. Oh. So so implementing systems like inpatient bed systems with different PASs and patient flow systems are all kind of HL7 integrations, and these systems have different electronic discharge summaries, and they become a source of truth for ADT data. Yeah, we're getting into the weeds now, but they're not well defined for secondary reporting purposes and end up out of sync with the feeding systems. Fire might be an opportunity to solve some problems, but how do I have my system update when the fire model changes? That's interesting.
Well, that's a great point, actually. Both of those things. So that's kind of not only being able to deal with the old and the new, and not having that become your problem. Right? So, Intersystems as a vendor, we put a lot of effort and time into our products to allow for those transformations to take place, and to help you deal with data from the HL7 standards all through to whatever else you might want to use. Now, I think Andrew's raising another point here around the secondary uses of the data. It's also interesting that HL7 and Fire don't follow, they're more of a JSON or an XML or a document type of data structure, which is for business analysts and people who want to use, things like Tableau or ClickView or Power BI, they're not looking at that type of data. So you do need to find vendors that are, I think you gave a good example before where the data is it's obviously messages that's flowing around. It's going to be transformed and transformed in such a way that it's going to be consistent. The data is then available for these secondary uses. It's a foundation for machine learning and AI, really. You don't want to have to be then having additional investments to go and start dealing with that stuff. It's really good if it's kind of one thought out process.
Absolutely.
And just to add to that, HL7 as a messaging system is very much a the concept is like a subscription to a message system. So if you miss it, it's gone. So there is no secondary use unless you're storing it then and there. And so modern systems need to be able to store the data for the secondary use.
Absolutely, yeah.
Hey, look, we've also got another question from Andy. It's funny, we've got Andrew on the panel here. Andrew Jahal asked a question. Andy as well. You don't need to be an Andy to ask a question or engage in this conversation, by the way. Put a question or a comment on LinkedIn and we can, or on YouTube or Facebook, even if you're watching live, and we can address those questions and comments there, even if you're not Andrew affiliated in any way. But Andy Ellis, a great point as well, which I think touched on something that came out of the survey too, which is around meeting, well, it touches on that government requirements point, but probably a broader issue around stakeholders within healthcare and engaging them. You know, when you're trying to provide data sharing or data exchange across systems and governments and social services and different parts of the healthcare sector, in Andy's example, it's in New Zealand, there's problems around politics and that gets in the way where agencies might not be interested in working together. It's not a priority. So that can be difficult to, even though technically you're able to then share the data, there's not that willingness from the participants to do that. And wondering if the panelists face any similar challenges to that as well.
I certainly have. And like, let me thank you firstly for being called Andrew. I think that's been useful in this conversation. But Andy, it's not just between agencies. So I've seen this in particular parts of the world where it can be in the same agency or the same company, and it's really just two department leaders building empires based on information. Non-sharing is power. And I don't have any good answers for that apart from how you deal with your organizational structure and trying to eliminate those barriers. But inside of the domain I'm more familiar with these days, Australia and certainly New Zealand, I think the message here is very clearly that to deliver healthcare in this country, the data has to be becoming open. There's a movement towards having all of the healthcare data getting into the My Health record and everyone moving towards FHIR. So at least hopefully, some things are changing. But I think it really does need government support, both the carrot and the stick.
It does. I was going to add to that. I think, and again, I'm repeating what I said before. You need to frame it in terms of optimization, patient outcomes, and patient outcomes ultimately, beneficial patient outcomes, and the component there to address sort of maybe some of the shortcuts, financial considerations. The optimization will make things financially beneficial, and that would be a very good way.
Andy's put a follow-up to your point. It's also between technology providers as well, not just in terms of those different stakeholders. Yep. Joseph, who's not an Andrew, has also asked a good question too, probably for Robbi, as you've said, and actually Intersystems as well as across industries. Do you find that the health workforce are more resistant to change than other workforces such as finance?
So the health workforce is heavily regulated. The processes are burdensome, and so in my knowledge with medtech startups, it's about regulatory compliance. The overhead is significant. Effort needs to be put into that. And if you're starting a company and you're coming out with a Class 2 medical device and you need to get certification around the world, you're going to be focusing your dollars and cents and all your resources on that. And so, now almost distracting, and I didn't want to use that word because it shouldn't be, to something that is adjacent to your core business is problematic. And so, this is the thing. It's the sort of, for our business as interoperability specialists, we find that's like a good thing and a bad thing. So it's not the core business for our customers. So what that means is that, it's not usually in their interest to build up a team internally that can understand the nuances of, open standards, let's just say. I mean, they can, but, they've probably, got better things to do. But the flip side to that is, because it's not their core business, then they're also not spending time on looking at that. They do it as they need to, almost. So we need like again, an overall overarching kind of a, reason to be interoperating.
Yes.
From my perspective, I would say it feels like the healthcare industry is quite often behind. But I, as a person, as a patient, I understand that. There's a element of there's a huge element of patient harm and patient risk in adopting things haphazardly or without understanding the implications. So I think it might manifest as a resistance to change. But as Robbi said, there's regulation, and then there's the real implication of what if we took some AI model and didn't understand exactly how it was operating, and we provided patient advice that led to really poor outcomes. So I think that element will always be there for healthcare.
Yeah.
Let me give one more example to this, and this actually, it's very similar to the putting it in the cupboard story, because it's a similar sort of a thing. This is working quite a long time ago for one of Australia's airlines, and we were introducing a new system that did like the current day monitoring of air traffic. And the notion was, so basically the story was that they turned it off and put it in the cupboard. But the reason there was they felt it was taking away jobs. And there may be some of that going on. Look, I don't know, but it wouldn't surprise me. And if we need to address that kind of a thing as well.
Yeah, I think there's an element here around the change management that can be talked about a bit as well. And so I heard an interesting story from Dr. Sankal Khanna at CSIRO, the Australian eHealth Research Centre, recently. And the example was they were able to, in a particular algorithm that they'd worked on and had the research around, they were actually able to predict patient outcomes. Deterioration, I believe it was. And so they had a lot of resistance to getting this model adopted. And there was all of the care things that we've talked about behind that. So they ended up saying, well, rather than predicting what's going to happen to the patient, why don't we take an established model, which was between the flags, that everybody understood and knew, and what we'll do is we'll just predict what the movement is on that scale sooner. And everybody understood that. It was already a given thing. They were just getting the answers a little more quickly than you would on the normal scale. So it's effectively doing the same thing, but one step towards getting to where you go might be some kind of compromise like that.
Yeah, that makes sense.
Interesting. I've got some good comments and questions coming through on the chat too. So if you're on LinkedIn and I've got something to share, by all means, drop it in live and we can address those. If you're attending live, if you're watching the recordings, keep those comments going in through and we'll keep the conversation going. I can see here, Richard, a rural GP, has raised that often rural doctors have several systems in one region or health complex, and navigating that is an issue. But also, he's mentioned age and literacy is a challenge too. So that's something there. Michelle has added as well to the conversation we're having before. Often also in healthcare, we're asking already overworked people to do additional tasks for something that they don't see the benefit of. So I guess that buy-in and getting that those participants understanding what we're doing and the elements of co-design are really important there too.
Yeah, and I think also just to realise that you have technology vendors and strategic partners that you work with all the time, and they may not be working with you in that area, but they may have answers and experience. They may have people who can help contribute to those problems. And particularly, with Intersystems, not just the wonderful people that we have on our team, but we have an incredibly good partner community with the likes of Robbi and the FST team. So you just don't know, and I think people should leverage that power inside the vendor as much as they can.
Yeah, and look, just again, coming from some of our background, we're very used to holding hands for customers for years after we do any kind of work. It should be very normal.
Yeah. I can see here Benoli has raised that even if we get, I'm paraphrasing a little bit, but I've put the comment up on the screen for those watching, that even with getting the interoperability right and all the agencies work together and we share the data, there's still limitations, Benoli says, on the how main identifiers are selected for secure messaging validation, and a lack of awareness on data sets that need to be shared for making the systems interoperable, and this is related to electronic discharge summary delivery. So I guess there's lots of, even when we get all of the bits and pieces aligned, having that knowledge and the capability is going to be really important too. We've mentioned a few times in this discussion, and it came up way earlier in the chat too, from David's asked about, the adopting generative AI and large language models, and we've touched on it throughout this conversation too. But I think it would be remiss of us not to dive into it in a bit more detail, and I'm sure those that are watching live might have additional comments or questions, so please do share that. But I guess that's what we're working towards here, I guess, is that, if we want to do these next generation things with artificial intelligence to hopefully address some issues around the workforce not having the capability to do, like the capacity, I should say, to address patients. If we want to introduce artificial intelligence, we've got to get the data in the right format and use it properly, right?
Yeah, absolutely. So the research does also talk a bit about the adoption of FHIR. Mm-hmm. So there's some interesting statistics in there. I think there's 13% of people claim to be using FHIR today, and that sort of feels about right. There's 13% who are undecided as to whether or not they'll use FHIR. 17% say no, and the rest are evaluating. But it's the 17% who are saying they won't use FHIR that's kind of an interesting situation. So certainly, as it relates to getting to that point where we have quality data that can be trusted, and we can use AI, more AI and machine learning, we really do need to figure out why is it that some companies and some people feel strongly about not using something like FHIR. And that's just one example. There are obviously, outside of healthcare, there are many other things. But a couple of examples I've heard recently as to why when somebody might not be interested in FHIR is these standards have they tend to come and go. It's going to be a large investment for me. Why would I bother spending money on that? So it's kind of like an apathy, here we go again type thing. And the other one is this, what I call the last mile. So, I've built a great app, and rightly, as a health tech, I'm focused on making sure that app does exactly what it does. It delivers the clinical outcomes or the fiscal outcomes that people are looking for. But then getting that into production and into the client environment can be the tricky part. It's the last mile. And sometimes the approach is to say, hey, I've got an API, and the customer, that's your problem to figure out how to get to my API. That part there can be very challenging for the customer, right? And that can make it, a project can sit, not ready to go into production because that hasn't happened. Obviously, for the health tech, you're not getting the cash flow from the product being implemented. So I think there will be organizations, health techs in particular, that embrace that and say, hey, it's more of a pain check. We're going to start chipping away at that to allow your interoperability problems. We're going to take on some of that for you. And when that happens, you'll see more of those companies that are then safely and with consent aggregating data, and it's going to have a standardized format. They'll be in a really good position to be starting to adopt and utilize and get the buy-in for things like generative AI.
Yeah. A couple of things. The trust with data. Privacy and security considerations should be obvious. They can't be understated. And maybe there needs to be more emphasis on those, talking about what's, how is the data, private. So in one case where one customer where they're introducing a mobile app, it needs to talk into a hospital, It needs to get data to be able to initiate a particular process, but it's a cloud-based service. So can they get like the list of patients from the hospital? You know, is that a thing? So that's something they're working through. But if we could solve, you know, solve that problem fundamentally, where there's no question that the data is private, no question, and it's a given now. So that will facilitate the uptake even more.
The other thing to say here, Robbi, is that it's already happening. I think people, in fact, I saw Bruno Braga at the Marta, was at the conference I was at this week, and gave a wonderful presentation. And I will paraphrase some of the things that I remember hearing about what he said. But the reality is that people are already doing this. They are already using things like ChatGPT and other technologies in their organization. They're experimenting. And he said in some ways that's heartwarming to see these interesting, curious minds playing with this stuff. So they obviously very quickly got out a policy around, you know, safe use, and gave people real examples of how to do it. But it is I think it's more of a situation of accepting that this is going to happen. It's going to be happening. So again, it comes back to education, putting the guardrails up, and helping people understand what they're doing, and how to do it safely.
Yeah, absolutely. I can see some more comments and more just agreements in the chat there too. And I encourage anyone that is watching live to leave any kind of final thoughts, because we might start to round out from both of you, just based on the discussion we've had on reflecting on you know, the results here and the report that's available to download. It's in the comments I can see here, and also in the podcast. So I guess final thoughts, or even perhaps recommendations to you know, healthcare leaders that might be considering implementing, or what to do with this information and where to from here, and any kind of final comments. I might start with you, Andrew.
Sure. I think to go kind of way back to the beginning around the data strategy, definitely being aligned, having your investments and your data strategy, use of data, all connected up to organizational objectives, and I think is very, very important. You know, if you are on a path of, let's say, building a single data repository, just validating that that is still the thing that's going to help you with your objectives overall. I'd say we've talked about vendor relationships and partner relationships. I think picking a technology partner that has a rich ecosystem and can bring more than just technology to your projects, because these are rarely just about the technology. It's got to be, you know, how the partnership brings the right sort of skills, people, extended relationships, know-how, all this kind of stuff around what you're doing, I think is really important. And I'm obviously biased, but I think an organisation that has a very strong healthcare focus is critical. Like yourselves, Robbi, I think that is something that allows that company to continue to build their expertise and knowledge, and can bring that to the table each time that they're consulted. And then just personally, I think, you know, we should be optimistic about this stuff. This is by no means a you know, a set forget. We've done it for the second year now, and I'm sure we'll do it again for another year. But it's showing progress, and I think we are demonstrating that as an industry, things are changing, and we are adopting the things that are headed our way. Yeah, just be optimistic and be proud of what we have achieved, and be look forward to the future as well.
Yeah, absolutely.
I'll add to that. So I agree. We absolutely have to be optimistic. There's no other way to really go about it. I think we need to look at the big picture, and the big picture is that overall, as a nation, we want to be investing in the health of our population. There really should be no other way to look at it. That's, you know, we want a healthy population, and to achieve that, we need a whole lot of different pieces put into place. And, you know, FHIR, as I said before, it's a stepping stone. It's one part of it. It's the first part. It's the part where we get the different systems to talk to each other. We've got a long way to go, and we have so much potential here in Australia to achieve that. So I think that's really important to keep our eyes, as you said, on the goal at the end.
Yeah, absolutely. Well, that's a nice way to wrap it up. I think that, you know, we've had some great engagement from those that are attending live. So thank you to to Charles and David and Andrew and Michelle and many others, Benoli as well, and Bernie, thank you for contributing there. I encourage anyone to continue the conversation going in the chat too if you're watching the recording, and you'll be able to access this episode in a few weeks on the Talking HealthTech podcast too. Well, let's leave it there. Andrew, Robbi, I really appreciate you making the time to have a chat. Thanks so much.
Thank you.
Thank you very much, Peter.
We hope you enjoyed this episode of Talking HealthTech. Make sure you like and subscribe and share this episode with someone who might find it valuable. For more information and resources about healthcare innovation, visit talkinghealthtech.com.